scenario where you will come across all types of shocks. So let's go into the discussion. Are my slides visible? Are my slides visible to everyone?
Yes, sir.
So what are the types of shock? So before I go into the case-based scenario, I just wanted to give a brief approach on basic this thing. So the types of shock are hypovolemic, cardiogenic, distributed, and obstructive. So one might be wondering, sir, where is septic shock? So septic shock can be a mixture of all the above. So septic shock is not only like a plain this thing. So it can be hypovolemic, it can be cardiogenic, it can be distributed shock. So what is the terminology which you come across normally? So you'll be hearing like shock, stroke volume, all that, systemic vascular resistance, peripheral vascular resistance, end diastolic volume. So I'll just make things simplify for you. So basically shock is nothing but it is a clinical syndrome due to impairment in tissue perfusion. So when there is an impairment in tissue perfusion, obviously there is inadequate delivery of oxygen. So when there is oxygen inadequate delivery, so what will happen? Your cellular metabolism will be gone and it will lead to cell injury. That will cause lactate and metabolic acidosis. So basically our body runs on three things. So cardiac output is equal to heart rate into stroke volume. So if you don't know anything also, just remember this easiest formula. So our cardiac output, which is like an adult 5 liters, usually depends on your heart rate into stroke volume. So stroke volume is indirectly dependent on again three factors. One is preload, one is contractility, the other is afterload. So you can see here, sympathetic nervous system, which is contractility, your peripheral resistance will be afterload, and your venous return will determine your preload. So obviously, whenever a cardiac output is reduced because of shock, the first thing body can do is it can only increase its heart rate because it is innervated by sympathetic nervous system. But it can't do anything related to your stroke volume. So it can't increase its preload by increasing venous return. It can't increase its contractility. It can't decrease its afterload or increase its afterload. So only compensatory mechanism body can do is increase its heart rate. So systemic vascular resistance is nothing but resistance to the blood flow offered by all of the systemic vasculature. Venous return is simple. So it is refers to the flow of blood from the peripheries back to the right atrium. So what are the compensatory mechanisms? So simple, don't get singing. So whenever there is a reduced cardiac output, definitely there will be high pressure barrier receptors which will be unloaded. So which will send the efferent signals to the vasomotor system. So definitely vasopressin will be increased in the secretion. So that will send signals to S node which can increase in the heart rate. And it will release inotropes in the body. So noradrenaline and adrenaline, catecholamines will be released. That will cause vasoconstriction. At the same time, drop in the blood pressure, your RAS mechanism will be activated, will in turn lead to salt and water retention and vasoconstriction. So when might be wondering what is compensated shock, decompensated? When I was in PG days, for me shock is only thing that where BP is low, we term it as shock. So it is not like that. So whenever you are seeing the hypotension means definitely the child is in the last stage. So what is compensated shock? It refers to a clinical state in which there are clinical signs of inadequate tissue perfusion will be there, but still the patient's blood pressure will be in the normal range. So body is able to maintain the blood pressure despite your impaired delivery of oxygen and nutrients to the vital organs. So decompensated shock is nothing but it is evidence of impaired perfusion that will rapidly progress to cardiac arrest. So you need to correct it immediately. So hypotension is a late finding in the most types of shock and may impeding the cardiac arrest. So hypotension usually occurs early in septic shock because of the mediators of the sepsis, where like nitric oxide and all will be produced, endothelial relaxing factor, which will produce vasodilatation and cooling of blood and reduce SVR. So decreased pulse pressure and prolonged CRT usually occur early in the shock progression. And if you see anyone with progressive tachypnea and tachycardia, they are indicators of worsening status. So later you will get the warning signs, loss of peripheral pulses and decreased level of consciousness. If definitely you see bradycardia and weak central pulses, then definitely the child is in non-impending cardiac arrest. So you need to act very, very fast then and there. So this is a simple slide. where you can see the compensated shock and uncompensated shock. Compensated shock, it will be tachycardia, then tachycardia to bradycardia. Initially, it will be oliguria, then it will be ATN and acute renal failure. And there will be tachypnea. This uncompensated will have acute respiratory failure. Initially, there will be agitated lethargy. In uncompensated shock, there will be altered mental status and encephalopathy. So minimal lab work, you send complete blood count, glucose, electrolytes, gas, lactate, superior vena cava oxygen saturation, which I will tell later, and blood cultures. So monitoring, if you don't want to remember all these things, just simple, this thing is shock index. So whenever you are giving fluid or inotropes or whatever, so what will happen? The heart rate should decrease, your systolic blood pressure should increase. Definitely, right? Whenever blood pressure is increasing, definitely means your go back to the formula of cardiac output is equal to heart rate into stroke volume. So main goal of hemodynamic intervention is to improve the delivery of oxygen to the tissues while maintaining the adequate perfusion pressure. So lactate should be less than 2. The main monitoring includes your CVP, lactate. So usually if you are able to achieve the effective perfusion, the blood lactate level should gradually decrease within 30 minutes. 60 minutes. So this is a simple listing, which I'll discuss in the later part. So go to the case scenario. So this is a case scenario which you, usually see in your common ER settings. So 4-year-old male child was brought to the hospital with complaints of fever since 3 days, cough and cold since 2 days, and not accepting feed well since 1 day. So you see fever, cough and cold, and not accepting feeds well since 1 day, and altered sensorium since yesterday evening. So it arrived to our hospital. Appearance is irritable, peripheries are pale, breathing is normal in your initial pediatric assessment triangle. So what is your interpretation here? Anyone? So what is interpretation and what is your intervention? What you want to do now? So is it stable or unstable? So is unstable, life-threatening condition. Obviously, we should start on O2 with 5 liters and ask it for 5 axis, and we need to the primary assessment. So in the primary assessment, ABCDE is airway is maintained, breathing wise respiratory rate is 30 per minute, air entry is there, occasional creps, SATs were 96%, 99% with O2, circulation wise heart rate is 180 per minute, pulses are bounding, CRT is 4 seconds, blood pressure vitals is 86 by 34 mm of Hg. In disability, your GCS is around 12 by 15 in each febrile. So what is your evaluation and what you want to intervene here in your primary assessment? Nobody wants to answer anything?
Hypovolemic.
Okay, can be hypovolemic shock. So what is your initial assessment after this part? So child is in, as I told you, when the BPs are maintained normally, it is compensated shock. For this child, it is decompensated shock. So because of the shock, his GCS was poor, causing hypoxic induced dysthing. So because of that, there is a secondary cerebral dysfunction. So you need to take a BPG, obviously GRBS. So as the child BPs are low, definitely we need to start fluid bolus. As the child is in shock, so we wanted to start O2 via face mask, just to improve the tissue perfusion and oxygenation status. So further course in the ER. So BPG was done, pH of 7.25, PCO2 of 45, PO2 of 40, bicarb 16, base deficit of -9, lactate of 3.5. So can anyone read out me what is the blood gas? So child is in shock, came to you with fever, cough, cold, abnormal, moderate sensorium levels. So child is definitely in decompensated shock. So you started fluid bolus and you have taken a blood gas. This is a blood gas. Anyone to interpret this blood gas?
Metabolic acidosis without compensation.
Okay, metabolic acidosis
Uncompensated.
Okay. So lactate is definitely high. So GRPS we have seen, which is low. So any child who comes with this thing to ER, so all of the cases, don't forget to check the sugars. So this child we have checked the sugars, it was 45, so again 10% extra 2 ml per kg. So we have suspected septic shock initially for this child. As such, the child is having fever, cough, cold, everything with warm peripheries and this thing and all, CRT prolonged. So we given like, okay, suspected septic shock initially. So we are given fluid bolus of 10 ml per kg. So vitals, the heart rate decreased from 180 to 165. Definitely the BP also got better from 86 by 34 to 92 by 36. So as they're improving the vitals, because as I was mentioning you, what you need to see is shock index. The shock index is nothing but when your systolic blood pressure is increasing, definitely your heart rate should decrease. What? Simple, right? When your denominator is increasing. So for this child also, the systolic blood pressure increased from 86 to 92. So your heart rate also came down. As per your, as I suggested, the formula, cardiac output is equal to heart rate into stroke volume. So here we have given a bolus which will increase your preload. So the heart rate has come down and BP got better. So we have given another fluid bolus as a improvement in the vitals. So after the second bolus, the heart rate decreased from 165 to 150. The blood pressure got further better, but not much. It was 92 by 34. It increased to 94 by 36. So after the second fluid bolus, child general condition also improved. Peripheries were warm. GCS, which was 12 by 15, became 14 by 15. So GCS is also improved. So anyone, what could be the reason for this low diastolic blood pressure? Did anyone notice when I read out the vitals? So what could be the reason for this low diastolic blood pressure? So what is a normal diastolic blood pressure for anyone? Minimal should be there. What is a minimal diastolic blood pressure? So minimal diastolic blood pressure at least should maintain is 25 mm of Hg. So what could be the reason for this low diastolic blood pressure in this particular child? Anybody wants to answer? So usually for all of us, whenever we see child is in shock, the first thing is we don't see which is low, whether it is systolic or diastolic. We just have the habit of seeing the normal BP or map, telling it as shock. So you need to see whether your systolic blood pressure is low or your diastolic blood pressure is low. Usually diastolic blood pressure needs to maintain at least minimum 25. Why? Because your heart will receive the blood, its own blood supply during the diastolic only. So here the reason is vasodilatation, septic shock. So blood is pooled in the peripheries. So that was the reason for this low diastolic blood pressure. So there is definitely white pulse pressure is there. So can we give another fluid bolus of 10 ml per kg? Because we have given 2 10 ml per kg, there was definite response. So can you go for another 10 ml per kg? Yes or no? So nobody wants to give any fluid bolus, or you want to go for inotropes? Anybody wants to answer?
We can go for inotropes.
Okay, definitely you can go for inotropes. So, but can you give another fluid bolus now? What are the recommendations suggest? So surveillance guidelines will suggest like you can give aliquots of 20 ml per kg. So you can go maximum until 60 ml per kg also if the child is fluid responsive.
Response.
Sorry. So if the child is fluid responsive, so the only thing you need to see if the child is having fluid responsive, whenever you are doing a fluid bolus, your blood pressure should get better, your heart rate should decrease. And at the same time, you should watch out for signs of fluid overload. So these are the 3 things which needs to be followed whenever you are giving a fluid bolus. Rather than simply blindly not knowing what type of shock. So shock can be anything. It can be distributive, obstructive, hypovolemic, septic, cardiogenic. You can't identify which it is initially with this history and this thing. So what in our hands is see the response, see for signs of fluid overload. So this particular chart, as someone suggested, we thought we can go for start of inotropes. So if you don't want to give bolus, what are the vasoactive medications to start?
Noradrenaline.
Okay. So why do you think noradrenaline is the best choice?
Low blood pressure for vasoconstriction main activity.
Okay, good. So why not dopamine?
Increases heart rate.
Okay, there are few studies which are done recently between since many these things since someone has replied like warm shock. So now the concept of warm shock and cold shock has been completely removed. So recently Suchitra ma'am has published a study. So you can go through that this thing. So that study says that there is no such concept of warm shock or cold shock. So there are so many studies which I want to clearly mention. This thing is that noradrenaline is the best drug of choice whenever initially you are suspecting the shock after your initial fluid resuscitation. It has decreased hospital stay. It has better outcome. It has better effects on the mortality and morbidity also compared to dopamine. So what do the guidelines suggest? So usually for surveying sepsis guidelines we take, so usually we suggest using crystalloids rather than albumin. Don't go for colloids in cases of shock in PICU or NICU. So use crystalloids for initial resuscitation. So like NS or this thing. So we suggest use usually balance or buffered crystalloids. Why? Because when you use NS, what will happen is you are increasing the chloride levels also, because NS will contain 154 milliequivalents of sodium and 154 milliequivalents of chloride both. So the best IV fluid is plasma light, not isolate. It is plasma light, which is equal to the human body composition, where your sodium is around 142 and your chloride is 92, which will not cause any hyperchloremic metabolic acidosis. So we recommend against using the starches in the acute resuscitation, like your gelatin or dextran or jellofusion. So we suggest against using gelatin in resuscitation of shock. So best option is crystalloids in that balanced crystalloids. So coming to the inotropes. So these are the various inotropes or this thing available. So one common misconception we all have is we don't usually categorize the cardiac medications. So for us, inotrope is an inotrope. So usually it can be vasopressor, it can be inotrope, it can be inodilator. So your noradrenaline is a potent vasoconstrictor. It is a vasopressor. It has no effect on cardiac contractility. It will increase the BP secondary to increasing the SVR, and it will increase the LV afterload. Whereas your dopamine, it will increase the cardiac contractility and it will cause peripheral vasoconstriction, and risk of arrhythmias is quite high, and increased hospital stay and increased risk of mortality and increased heart rate is one common side effect with dopamine. So dobutamine or milrinone, they are both are inodilators. Basically, they will increase the cardiac contractility, and at the same time, they will reduce your systemic vascular resistance also. So that is the reason dobutamine and milrinone are termed as inodilators. So adrenaline is your increasing heart rate and cardiac contractility. So you can go until 1 to 0.05 to 3 mics per kg. Usually maximum you can go until 1 mic per kg. So once you reach more than 0.3 mics per kg, so adrenaline will also act as a vasopressor. So we suggest using norepinephrine rather than dopamine in children with septic shock. So usually after 40 ml per kg, if the patients continues to have evidence of abnormal perfusion, either epinephrine or norepinephrine may be administered to the peripheral vein if central line is not readily accessible. So dopamine usually will be started if both adre and noradrenaline is not readily available. So then only we need to start dopamine. Otherwise, the first choice is noradrenaline. If you are suspecting cardiogenic shock, adrenaline. So further course of this stage, so we are given 2 fluid bolus of 10 ml per kg, total 20 ml. So we have started noradrenaline and maintenance fluids and given antibiotics and shifted the child to PICU for further management. So vitals were stable for next 24 hours and child was doing well. So now this child is started deteriorating after 24 hours with worsening shock and distress. So vitals again, as heart rate came down to 150, again it increased to 165. Your BP, which was normalized and doing good, suddenly decreased to 72/50. Peripheries were cold, CRT is prolonged more than 5 seconds, and child is definitely tachypnic, febrile. So we thought, okay, we will see the gas, what is happening. So gas was done, VBG, which was showing pH of 7.1, PCO2 of 55, PO2 of 32, bicarb of 12, base deficit of -14, and lactate increased to 4.5. So definitely there is a worsening because your heart rate increased, your BP worsened, your child is become tachypnic. So can anyone interpret me what is the blood gas here? What is the interpretation of this blood gas?
Mixed metabolic acidosis.
Sorry. So metabolic acidosis is there. Along with it, is there anything?
Respiratory also.
So there is both respiratory and metabolic acidosis. Both are there. So definitely, when even the child is tachypnic, still your PCO2s are quite high. So there is both mixed respiratory plus metabolic acidosis. So usually this child, we thought, okay, he might respond to fluid. So we have tried another fluid bolus of 10 ml per kg. We also increased noradrenaline to 0.2 mg per kg. Vitals further worsened, his heart rate further worsened to 180, distress also worsened. Now the child is even not maintaining sats with face mask also. So with 5 liters, we have increased to 10 liters also, still the child is not maintaining. So why do you think the child vitals have worsened?
Cardiogenic shock could be a reason. Like worsening after fluid bolus, we need to think about cardiogenic shock.
Yeah, definitely. Okay, good. So when you are giving another fluid bolus of usually after starting inotropes, better to give in small allocots because you don't know, because initially it could be hypovolemic, later the cardiac part might settle in. So when you are giving another fluid bolus after once you start inotropes, go slowly 5 ml per kg and see for any signs of fluid overdose. So as someone has pointed out, definitely it can be cardiogenic. So child is not maintaining, child is fluid overloaded. So what is the reason for deterioration in this child? So definitely, as someone has answered, it is fluid overload. It can be cardiogenic shock. So why there is narrow pulse pressure? So what is pulse pressure? Anyone before going into whether it is narrow or wide? What is pulse pressure?
Difference between systolic and diastolic.
Systolic pressure minus diastolic pressure.
Okay, good. What is a normal pulse pressure?
20
Would be 20 to 30.
20 to 40.
Okay, good. So initially this child, we know there is a, usually it is between 30 to 40. So if you see like normal this thing also, it is around our blood pressure. If you see also it is normal what that is, it is 120/80. So what is the pulse pressure? 120 minus 80, it is 40. So usually we will tell you between 30 to 40. So what is narrow pulse pressure now?
Less than 20.
Okay, why do you take these terms narrow or wide pulse pressure? Why? Good answer. Definitely it is less than 20. That is the reason we call it as narrow pulse pressure. So why do you need to use these terms?
Perfusion. For perfusion.
Okay, perfusion is low. That is the reason child is in shock. That is really narrow. But why you want to use those terms of narrow or wide pulse pressure? Why? Yeah, we can simply have these terms, right? BP is not normal as per the age. Less than 5th percentile, it is uncompensated shock.
Are associated with coronary perfusion.
Sorry?
Low diastolic pressure are associated with poor coronary perfusion.
Okay, sir. Okay. So what is mean by narrow pulse pressure? So what is low in narrow pulse pressure? What is low in wide pulse pressure?
Diastolic BP will be rising in narrow pulse pressure as a result of compensation due to shock.
Yeah, but-
Compensatory mechanism.
okay. So my question is here: what is low in wide pulse pressure? What is low in narrow pulse pressure? Your systolic or diastolic?
Systolic will be low.
So your systolic will be low in your narrow pulse pressure, right? So in your wide pulse pressure, your diastolic will be low. So what could be the cause? Why in narrow pulse pressure your systolic has to be low and
Sir,
why?
in aortic regurgitation,
Sorry.
in aortic regurgitation, you will see wide pulse pressure, regurgitation regions. Coronary diastolic filling is low, and we will see narrow pulse pressures.
Okay, sir. I agree your point. So basically, why we get to this point of narrow pulse pressure or even pulse pressure, or it is wide or narrow? Why? Because so definitely when you are suspecting, see the pulse pressure when you see hypotension. See whether it is narrow or wide. So as all of you are telling, this like wide pulse pressure means your diastolic is low. So when your diastolic is low, basically what does it indicate? Your filling pressure is the problem.
Hmm.
So when your filling pressure is the problem, usually it could be any peripheral pooling of the blood, or it could be, as I pointed, it could be any regurgitation or your PDA. All will be having this wide pulse pressure or initial stages of septic shock, everything. So if there is a narrow pulse pressure, it could be hypovolemic, it can be cardiogenic. So your preload is a problem here. So it can be hypovolemic, it can be cardiogenic, it can be obstructive, will all be having your low systolic. It can be contractile problem or preload can be the problem. So is another fluid bolus a good option in this child?
No.
Why?
As with previous bullet, child distress is increasing, heart rate is increasing, BP is not improving, means child is not responsive to fluids.
Yeah, so no point giving another fluid bolus. So does this child require intubation now?
Yes.
Sorry. Yeah, definitely this child requires intubation now. So what are the drugs to be added?
Inodilators.
So you can think of adding another inotropes. So what are the signs of volume overload? So first thing is like increasing your heart rate and increasing your respiratory rate. Later part only you will see this hepatomegaly, Krebs or wheezing. So whenever you are giving a fluid bolus, if you are seeing the increasing the heart rate or increasing the respiratory rates, definitely you need to stop the fluid bolus there. The last part is your crepitations or wheeze or tender hepatomegaly. So the first thing is like, this is the graph which is taken from the septic shock, this thing. So you can see here the fluid trends. So initially there is a nice response. So the rise of pulse rate of more than 10 per minute over your lowest value is the earliest indicator of fluid overload. As you can see here, the pulse rate will be the first thing which will increase. The last part is your hepatomegaly or Krebs. So the earliest indicator is your pulse rate. So if your pulse rate is high than your lowest value, definitely it is earliest sign of fluid overload. You need to stop the fluid bolus there. So in your person distress and shock, we decided to intubate the child. So for this particular child, we thought of first thinking of physiological difficult airway. So definitely we have to correct bicarbonate. So this particular child, we have given ketamine and vecuronium and given fluid correction, everything, and we have intubated this child and connected to mechanical ventilator. So cardiologist came and did echo. So 2D echo was done, which was showed ejection fraction of 25%. So definitely the child is in cardiogenic shock. The child was started on Millone infusion. So child is connected on assist PC control mode with moderate settings. RT line was secured along with your intrajugular central venous catheter was also secured. So child was continued on Millone of 0.5 mics and Noradrenal of 0.2 mics. So we did correctly only. The child came in hypovolemic shock. We are given fluid bolus, start on Noradrenal. Then later we thought it could be cardiogenic. We tried both fluid bolus and inotropes. So we diagnosed it as cardiogenic. So we started everything correctly. But now again there is further worsening. Urine output has reduced to 0.5 from 1 ml per kg, and your arterial blood pressure now it is 65/40. So we are doing everything correctly only, right? So why is this further deterioration in this child? Is it your inotrope selection, or is it your uncorrected acidosis, or electrolyte abnormalities, or other issues? So what do you think in this particular child of one of their 4 causes? Anyone?
Corrected acidosis.
Okay, so whenever you think that you started everything correctly, still your BPs are not getting better, you need to think of uncorrected acidosis. Okay, so your inotrope selection. So do you think our inotrope selection was correct? We have started on Milrinone.
And noradrenaline would have been better.
Dobutamine should be
Okay, dobutamine we can. Okay,
Noradrenaline, sir.
so noradrenaline, you think it should be stopped, right?
Okay.
Okay, I agree. Anyone further answers?
Adrenaline, sir.
Yeah, good answer, adrenaline. So why adrenaline or dobutamine? Which one you want to choose in this particular child?
Adrenaline, sir.
Adrenaline.
Okay, why not dobutamine or Milrinone? What is wrong with both of them?
They both cause vasodilatation, further fall in BP.
So both dobutamine and Milrinone are. Who is the one who answered this question? Who answered this?
Dr. Rafi, sir.
Okay, your sir, your PG sir or
Practitioner, sir.
okay, sir. So that's a very good, excellent answer, sir. So as such, the initially I told you, child was didn't respond to fluid bolus. Then we have to think of cardiogenic shock, as nicely everyone pointed out. So we thought it could be cardiogenic shock, and our echo also showed the same thing. So child worsened, we intubated, all did correctly. But as such, the guidelines would suggest that if the child is in still there is an uncompensated shock, right? Your BP further dropped. So the guidelines also will suggest that the first drug should be adrenaline if BPs are low. If BPs are lowish to normal range, then we can start on dobutamine. And whenever we start everything, still there is no response, you need to think of uncorrected acidosis. You need to think of your inotrope selection. You need to think of even electrolyte abnormality. Sometimes your hyperkalemia or hypocalcemia might be there in the background. So whatever you are doing, it will not show the response. And you need to see the rhythm issues also. So in such cases, you need to look for obstructive shock, electrolyte abnormalities, uncorrected acidosis. So this child was started on adrenaline infusion. We have stopped Milrinone. Over the next 6 hours, BP stabilized to 96/70 and peripheries were better. So further progression after 12 hours, again child were further worsened after initial improvement. So BP have dropped and there is increase in the heart rate. So we did everything correctly. We have corrected hypovolemic shock, we have corrected cardiogenic shock, we thought inotrope selection was wrong, we have corrected acidosis, everything we did correctly again. But why again there was a further drop in the BP and increase in the heart rate? So what do you think the reason could be for the worsening? Is it cardiogenic shock or is it capillary causing hypovolemic shock? So who wants to go for option A? Who wants to go for option B?
Capillary leak causing hypovolemic shock, sir, because the lactic acidosis is there, the sepsis component will be there, and the capillary leaking will be there.
Okay, sir. So don't you think, sir, cardiogenic shock could be worsening?
It should have improved after adrenaline, no?
So exactly. So here initially the child showed improvement. So we need to, we can't be like a straightforward. So in cases of septic shock, my point in this particular scenario, which we commonly come across. So usually we initially come across hypovolemic, then we'll correct all that. Then we think of cardiogenic, we start inotrope. So we can't be adamant, it is only cardiogenic shock. Sometimes because of your sepsis part also, there will be leakage. It might be capillary leak, which is ongoing. Whatever you are giving the inotrope, it can only increase your contractility. So it can't replace your preload. So definitely it can be capillary leak causing hypovolemic shock. At this particular time, the only thing which can differentiate both of them is see if there is any response to inotrope or response to fluid bolus. So you can give one small LA pot of 5 ml per kg, at the same time increase inotrope, see the response, and see the lactate levels also. So initially, what we do is we think it could be cardiogenic shock worsening only. So we increase adrenaline, there is increase in the BP. But as such, I pointed out, if there is increase in the BP, the heart rate should come down. But in such cases, an increase in heart rate was there, and there is further decrease in the urine output. So we thought it could be definitely capillary leak because urine output is also reducing. So we are given 3 electrodes of 5 ml, 5 ml, 5 ml slowly over the next 1 to 2 hours. So good response was seen. So after the fourth bolus, there is no response. And we have increased inotropes now. So that also is showing now no response. We have stopped Milone, we have started adrenaline. Now we are on adrenaline of 0.3 mics and already is going on. Now child is not responding to neither fluids nor inotropes. So what went wrong here? Why there is no response to fluid bolus or no response to inotropes?
Obstructive shock.
Okay, very good. So why do you think, sir, it is obstructive shock?
Child is on mechanical ventilator.
Okay.
VIP, PAP.
Sorry. So, okay, why mechanical ventilator? Why do you think it is obstructive shock?
Pneumothorax might have caused some problem.
Okay. So this particular child, okay, we can think of pneumothorax, but X-ray was done. We suspected the same, but X-ray was showing no pneumothorax. So what could be the next cause?
Pneumomediastinum.
X-ray is normal, sir. Normal in the sense there is no pneumomediastinum or pneumothorax.
Abdominal compartment.
Okay, so somebody has told abdominal compartment syndrome. So why do you think abdominal compartment syndrome?
It could be high PEEP settings and expanded lungs compressing heart for preload and afterload.
Okay, sir. Sir, one thing I want to point out here, usually what they tell is high PEEP, PEEP of 7 is actually good for the heart, sir. Usually in such cases of cardiogenic shock where your heart is struggling, basically your contractility is the issue and LV is failing, the squeezing of the heart by increasing lung expansion by giving the PEEP actually will help your contractility of the heart, sir. So that is not the cause here. So one thing I want to clear here, usually in cardiogenic shock, usually we think that it is not the problem. So we can keep PEEP of 5 only. Usually we don't go more than 5 PEEP in cardiogenic shock. But PEEP of putting 7 will help in such a way that it will increase the lung expansion and squeeze the heart, and it will also reduce the pulmonary edema. So definitely not. So any other causes? So 2-3 people have pointed out it can be obstructive, very good. So it can be pneumothorax, ruled out. So PEEP not the answer. So any other causes? So somebody told me it could be abdominal compartment syndrome. So why? Because so whenever you think of this thing, so we did everything correctly only. So we have corrected hypovolemic, then we corrected cardiogenic shock. So we did everything correctly only. So again we came to the same thing. So unresolved acidosis, we need to think of abdominal compartment syndrome, adrenal insufficiency, and worsening cardiac dysfunction. As I told you, it could be hyperkalemia, hypocalcemia, hypoglycemia. So you need to check your sugars, you need to do 2D echo, and you need to think of any adrenal insufficiency. And so for this particular, we have given corrections of calcium, everything. So bicarb was given corrected. But usually what we need to forget is whenever we are giving fluids and fluids, usually we don't see the abdomen part. So our appearance or our eyes will every time go to the chest, X-ray, vitals, monitor. So we see both clinical end, but you don't see the abdomen part. So whatever the capillary leak is happening, the capillary leak will be happening in the abdomen also. So the fluid will be leaking. So after some time, there is no space to expand in the abdomen. So after ruling out other causes, found out the child is having tense abdomen. You measured the IAP, intra-abdominal pressure. We have diagnosed it as abdominal compartment syndrome due to capillary leak. So we did abdominal paracensis, leak slowly, and child improved gradually. So child gradually improved over next 72 hours. Able to achieve good negative balance. We have weaned off inotropes. Child was extubated to room A, discharged to home after 10 days of hospital stay. So if you're able to answer this slide at the end of this talk, at least I was able to. So in hypovolemic shock, the preload is decreased, the afterload is increased. So in cardiogenic shock, the problem is your contractility. So contractility will be low. And your obstructive shock, the problem is there is some obstruction which is causing the decreased flow to the heart. So preload will be decreased and your contractility will be normal. In your distributive shock, definitely the peripheral pooling of the blood is high. So the preload will be low. At same time, your afterload will also be low. Why? Because you are decreased systemic vascular resistance. Thank you, everyone. So we'll conclude this session of this thing. Any doubts?
Sir, pulse pressure, please explain once. Narrow pulse pressure and wide pulse pressure.
Okay, sir. The pulse pressure is usually we term it as narrow pulse pressure when it is less than 20, sir.
Okay.
Okay, so in narrow pulse pressure, usually if you do for this particular child only, it is 70/50. So definitely your diastolic, this thing is good. So your diastolic, this thing is good means definitely what does it indicate? The filling is the problem in diastolic, but here the filling is not the problem. So it can be either your preload or contractility can be the issue here. So it can be hypovolemic or your cardiogenic part might be the issue here, which is causing your low systolic pressure. So in wide pulse pressure, the problem is your diastolic can be very, very low of 25 to 30. Why? Because the blood is not pumped into the center. It is spread along your peripheries. It can be because of your sepsis mediators, which is causing the peripheral pooling of the blood. So what you have to do is you need to give something which will cause an increased vasoconstriction. So you can give any vasopressor which will pump the blood back to the heart. And at the same time, you need some drug which will increase your SVR, so you need your BPs are maintained.
Thank you. Thank you, sir.
Thank you. Thank you, everyone.
That's